Good afternoon. My name is Bellal Joseph. I'm the panel leader for the Geriatric Trauma NTRAP Action Plan. Thank you for joining. This was the first research agenda ever created for geriatric trauma. For the first time, a multidisciplinary group convened to discuss research. And you can see here that, the real big picture is the conclusion indicated that research is required in many more areas than those mentioned below. And there was a lot of work that really needed to be done. The high priority questions were pain management and frailty guided protocols. However, I can tell you that there was a big variation in what we really needed to do. The panel consisted of over 24 members, consisting of a multidisciplinary team, experts from trauma, geriatrics, anesthesiology, and orthopedics. The panel also included individuals with diverse expertise in all stages of trauma care, ranging from injury prevention to rehabilitation. And the panel really comprised both clinical and non-clinical professionals. You can see the area of expertise and profession distribution here. And we really wanted this because we feel like we pan over a lot more areas with geriatric trauma. We organized the questions using a conceptual framework perspective to ensure that all stages of trauma care were included in our original list of questions. And this panned from injury prevention, triage and transportation, in-hospital care, and you can see care transition and rehabilitation. These are some of the most important or top priority questions for our team in terms of topic and frequency. You can see trauma centers and the use of geriatric specific protocols versus not using them, the use of geriatric protocols and how they impact long-term functional outcomes, regional anesthetic techniques for lower limb orthopedic injuries and how they improved outcomes in geriatric trauma patients, and then how do regional anesthesia versus oral and IV analgesics compare with just oral medications in respect to mortality, pain, delirium, discharge disposition, and functionality of up to 6 months. What really stood out, our focus extended beyond the questions we should ask and encompassed the type of research required. After identifying the need for more important interventional trials, we conducted a secondary analysis and looked at the top 25 questions and evaluated proposed interventions. You can see the type of research, more interventional clinical trials really were what was needed, and system-based care research. Notably, all panel members emphasized outcomes with a particular trend towards delirium and cognitive function after trauma. Our findings regarding the type of injury and were also intriguing as rib fractures emerge as the top priority. I mean, we deal with this a lot, and this implies that more research is necessary in this arena. I think that's one of the things that really stood out, is that this is something we do every single day, caring for these patients, and so the fact that it was a high priority of what stood out really emphasizes the need and urgency for geriatric specific protocols for trauma patients. What are the biggest gaps? Again, gaps in specific types of research design. I think one, interventional clinical research, understanding geriatric specific protocols, and then being consent, complexity of injuries, special conditions, comorbidities, geriatric specific syndromes that really stood out. I mean, we categorized our gaps into two parts: gaps in types of research and gaps in research projects. I think furthermore, while we have a considerable amount of research focusing on clinical outcomes, there's a striking lack of research on patient-reported outcomes as well. And you can see here that even delirium was a high priority outcome as we looked at our data. When we looked at the biggest gaps, again, regarding the main research topics, we identified several areas that require attention. First, pain management, particularly in rib fractures, really needs focus. Second, frailty is another crucial area that warrants our attention. We recommended that frailty-guided consultations become a standard part of protocol screening, and then interventional trials related to this. And then finally, anticoagulation therapy in older adults has emerged as a significant concern. Fortunately, There's new research coming out in this area, but we still have a lot more to do, not only of how to reverse and treat, but how to extend and restart these medications. What are the most important questions to answer? Really, answering this question is quite challenging. There's so much need, but I believe that once we prioritize research questions, our objectives should be to motivate and involve researchers in these areas. And so how do we encourage researchers to focus on geriatric trauma prioritized topics? I think in older adult trauma patients, questions like what is the effect of frailty-guided consultation on palliative care services, on adherence to evidence-based management guidelines when compared to just attending physician discretion. We must spread the findings of the study. I think that's another area that researchers carry out more, not only carrying out more interventional trials, but actually how to disseminate those. And then the big question is how to fund more interventional clinical trials in geriatric trauma, because that's a huge question. And there's a lot of organizational work happening to get to a network, if you want to call it that, for this. Some closing gaps in what's next. I really think the NTRAP study has generated a ton of data and is like treasure that needs further explorations. We're just opening Pandora's box. Secondary analysis of the data within our own geriatric trauma panel is our plan. I mean, understanding not only our primary or high level priorities, but also our medium and low priority questions, I think is important. Both clinical and patient reported health outcomes. I think across the panels we find interesting common trends that can't be understood by just one panel, and geriatrics is a great example of this. I suggest to review cognitive health outcomes across all panels, and particularly with like the neurotrauma panel. I think that this secondary cross analysis is critical. I think it's time to review all trauma systems related to these questions and preventive measures to help develop these things. The full manuscript really goes into the detail of this, but our entire infrastructure and prevention treatments is really based on a certain population, and I think our geriatric trauma has really emphasized that we need to spend more time exploring outside of our everyday application of adult trauma guidelines to geriatric trauma patients. Thank you so much for your attention. I look forward to questions and connecting soon.